We'll keep moving along. Our next presentation is by Roshini Moodley Naidoo and Lauren Baker. They'll be talking about health system strategies to address disparities in hypertension management and control.
Hi, everyone. My name is Roshini Naidoo. I am faculty at the College of Health Solutions, instructing in mainly healthcare systems and a member of the Safety Net Advancement Center, where I support our team on research projects. Our proposal today involves a conceptual model for healthcare systems to address disparities in the management of hypertensive disorder of pregnancy, a very commonly occurring condition in pregnancy and one that has very significant adverse outcomes as well as very significant disparities in those outcomes. My partner in the presentation is Lauren Baker, who is a senior research manager in the National Safety Net Advancement Center and also an alum of College of Health Solutions, having graduated with her master's in science. We have many people to thank for the work that has gone into preparing this particular proposal and developing the conceptual model. Professor Riley, Professor Chen, Professor Martin in particular, and then our partners, Valleywise Health System, Dignity Health Medical Group, and Phoenix Indian Medical Center. I said a moment ago that this is a conceptual model, meaning that it has not been implemented. We designed this model as part of a funding proposal to address maternal outcomes, and it is our hope that we will be funded and then have the exciting opportunity to implement this proposal and this model so that we can make a contribution to improving disparities in maternal outcomes in the United States. I will hand over to Lauren for an overview of the model.
Thank you, Roshini. All right, so we're going to start off with some background information about HDP. Hypertensive disorder, also as HDP, continues to be a significant cause of maternal and fetal morbidity and mortality during pregnancy worldwide. This includes conditions such as preeclampsia and eclampsia, all which involve increasing the blood pressure due to the natural changes that occur during pregnancy. HTP is responsible for about 31.6% of deaths related to hospital deliveries. In the US, there's about a 25% increase in the prevalence of HTP that happened between 2017 to 2019, making this affecting at least 1 in 7 mothers across the nation. In addition, there has been studies shown that notable differences in health and pregnancy outcomes based on their race, their ethnicity, socioeconomic status, access to resources. They've also found that African American and Native American women are 2 to 3 times more likely to experience HTP outcomes. So this table in front of us shows the rate of HDP and prenatal visits among African American, Native American, Hispanic, white, and other race and ethnicities in Arizona. However, it is concerning that the rate of expectant mothers receiving prenatal care in the first trimester is lower for women of color. We can see here that African Americans, it's at 60.3%, Native American, 57.1%, Hispanic at 64%, all in comparison to white. Equally troubling, the rate of expectant mothers of color who receive no prenatal care is greater than these white expectant mothers as well.
Thank you, Lauren. So our goal with this study design is to mitigate social risk factors, and that would be to increase prenatal and postpartum clinic visits, which would have then an impact on the management and control of hypertensive disorders of pregnancy once those disorders are diagnosed, and subsequently reducing disparities in health outcomes. That is the etiological flow of the goal of this conceptual model that we've designed. We've started and placed such prominence on social risk factors as the starting point, as well as the commonality through the entire maternal care continuum, due to the significant impact that social risk factors and social determinants of health have in maternal outcomes. It is estimated that more than 50%, close to 55%, of maternal adverse outcomes from hypertensive disorder in pregnancy being directly attributed to social determinants of health. So a very significant factor that starts and then continues to perpetuate disparities in maternal outcomes. Our intervention involves designing and implementing a maternal equity bundle. We've designed the equity bundle based on a bundle that has been implemented by an organization called AIM, that is the Agency for Innovation in Maternal Care, that works across states, as well as guidelines that have been advocated for by the Society of Obstetricians and Gynecologists in the United States. The intent of the bundle is to improve follow-up during the entire maternal journey. So that would be from prenatal all the way to postnatal care. And by follow-up, we mean patients visiting for their appointments with their obstetrician or with their PCP, which then allows the clinician the opportunity to make a diagnosis, to determine treatment, and then to monitor the patient's response to treatment as a way of controlling blood pressure. That would be both systolic and diastolic blood pressure, and through controlling blood pressure, improving complications of hypertension. That would be maternal as well as neonatal complications. We designed a theory of change that involved several different components. The first was an appreciation that in the current status quo, there are outcome disparities that are well documented. There are treatment disparities also well documented, and this very prominent contributing factor of social determinants of health. The second component is our actual intervention, the maternal equity care bundle, and I'll speak a little more about that in the next slide. We then designed mediator outcomes as well as primary outcomes. Mediator outcomes are linking outcomes, so essentially linking the intervention to our definitive outcome, which is our primary outcome. Our mediator outcomes for this project are the actual mitigation of social determinants of health, and that would be the patient's account of whether identified social risk factors, such as transport or food insecurity, have been mitigated or not, which is very different from a health system determining if a social risk factor has been mitigated. A second outcome would be patient facilitation. So, for example, if transport is a barrier that was identified during screening, then activating and creating the patient factors, motivational factors that would enable the patient to take steps to engage with the solution. And the final mediator would be the increased clinic visits, and that would be both prenatal as well as actually, it would be prenatal as well as postpartum following delivery. The outcomes are what I've already described, and they're a combination of clinical outcomes, hypertension, that would be diastolic and systolic pressure, then actual outcomes, maternal and neonatal complications, which we have designed a composite measure for, and then very importantly, the patient's perspective of whether outcomes have improved, and that we would capture through a patient survey. And then finally, we would measure the actual disparities. So that would be an outcome that is disaggregated by race and ethnicity. So we'll conclude just by speaking a little more about the equity bundle. So a bundle is an integrated set of evidence-based practices or activities. A bundle is intended to eliminate variation in care practices. The essence of a bundle is that it is a high reliability activity or a high reliability guideline or process that is followed. Our maternal equity bundle consists of several different items and 2 dimensions. And I mentioned earlier that these are evidence-based based on the organizations that we adopted our equity bundle from. The first dimension is the social determinants of health. And here we have hardwired into our process a reliable set of steps that involve screening, an actual patient interview, the referral, and the referral being kept. All of those in aggregate are referred to as a closed loop system. We often talk about closed loop systems across healthcare systems. So this would be a closed loop system for managing or implementing an SDOH bundle. The second dimension is patient facilitation. And here we have envisioned and articulated a process that maps out culturally appropriate or culturally sensitive SDOH process from screening all the way through a referral being kept. That would involve culturally appropriate forms of screening, culturally appropriate patient activation steps for patients once interventions are identified, for patients to engage with those. It would involve health literacy, and very importantly, it would involve shared decision making, which is quite different from a prescriptive view to a social determinant of health being identified, where a patient is simply given a recommendation. In our model, we've conceptualized that actually involving patients in how that intervention is designed, that social risk intervention is designed, would be key to mitigating the risk factor. And our final slide is essentially a summary of what the outcomes are. And we've conceptualized from implementing a maternal equity bundle, as I've just described, that women of color who receive the intervention will have their blood pressure control improved compared to a usual care arm. Women of color who receive the intervention will experience improved outcomes. So those would be the complications from a raised blood pressure compared to usual care. And finally, women of color who receive the intervention will report much greater level of satisfaction as measured by patient experience compared to usual care. Thank you very much for giving us the opportunity to present to you today. We would be very happy to take any questions that you may have. Thank you, Lauren.